Good evening, ladies and gentlemen. And if you're watching from other parts of the world, good morning and good afternoon. My name is Jung-Chul Park. I'm from Yonsei University. I'm a periodontologist, and I am also a clinical assistant professor at the Department of Periodontology. So, I'm your moderator for today, and I will be presenting a surgery for you from Dr. Jung-Chul Park. He is one of the most famous surgeons in Korea. But in case you don't know, I will give you a short introduction about Dr. Park. He studied at Yonsei University, like where I am now, and he became a periodontal specialist, and he became a professor at Dankook University in Korea. And then after that, and now he is an owner of a private practice in Seoul. So he's working now as a general practitioner from being a periodontal specialist. So it will be very interesting to see the type of surgery he has for us today. So I will give you a brief introduction to the case that we are about to see. And the title of the case is Immediate Implant Placement with Transmucosal GBR using the Untuk technique. And you may be wondering, what is Untuk technique? Untuk in Korean means a barrage, like for a reservoir where it holds the water. So now you can kind of imagine the type of technique it is. It's kind of like building a barrage so that the material gains stability. So the materials that we'll be using today is the bright implant bone level and osteoxeno collagen and osteoxeno, the particulate version. So let me give you a brief introduction to our patient. She is a 77-year-old female patient, and the chief complaint was difficulties eating due to lack of teeth. And the presenting illness were the missing teeth on these areas: 17, 16, 15, 11, 24, 25, 26, and 37. So a lot of missing teeth. We can see why she has trouble eating. And she has generalized gingival redness and swelling, deep pockets, and furcation involvement on the tooth 3-6. And she has loss of posterior teeth, so a loss of bite in the collapse of the bite in the posterior region. And she has pathologic migration of many of her teeth. The treatment plan was scaling and root planing, extraction of the teeth 1-4, 3-6, 3-8, and 4-1, and implant placement on 1-6, 1-4, 2-4, 2-6, and 3-6. So let me show you the X-ray. You'll probably gain a better understanding by looking at this picture. So you can see from the X-ray here that she has a vertical defect in the right posterior maxillary area. And also you can see that she has a missing 1-1 and also the missing posterior teeth on the upper left area. And also we can see that the tooth 3-6 looks periodontally hopeless. So today we will be extracting the tooth 1-4, which seems to be a root rest, and we'll be placing implants on 1-4 and 1-6 area. So the implant on 1-4 is immediate implant placement, and we'll also be performing a ridge augmentation procedure whilst doing implant placement. And we'll be performing ridge augmentation using volume-stable xenograft material using the Untuk technique. So this should be a very interesting case given the very extensive defect in this upper right area. So these are the clinical photos. As you can see, we can see that she's very periodontally compromised. She has a massive defect in this upper right sextant. And also, we can see that she has some general problems with her occlusion as well. Very deep bite in terms of her incisor relationship. And also, she has many caries, and there's problem with her oral hygiene. Okay, so this is the area of surgery on 1-4 and 1-6. We can see that there is actually plenty of bone height for implant placement, given that there is 15 millimeters in the area of 1.4 and 10 millimeters on 1.6. So there is no need for sinus augmentation. But we can see that in the posterior area, there is a vertical ridge defect, as I previously said, and there is a horizontal defect on the area of 1.4. So we will be using this bright bone level implant. So this is kind of different from the superline implant that we are used to. The characteristic of the bright implants is that we also have external type of connection with these implants, but they can be very advantageous in the anterior region where the ridge is quite thin. But in this case, we will be using an internal connection of the bright bone level implant. It has very good joint stability, internal hex of around 2.1 millimeters. And as we can see, very characteristic of today's implant fixture design, it has very aggressive and deep thread designs, and it has triple cutting edge. So I would say that this is an ideal implant to be placing for an immediate implant placement protocol. So this is the bone graft material that we will be using today, the Osteon Xeno. Previously, the Osteon bone material used to be synthetic version. Now we have the xenograft, which is bovine origin and with osteoconductivity, highly interconnected porous structure similar to human bones, and complete removal of organic substances. And this is the collagenated version of Osteon Xeno. And I believe it has approximately 10% collagen mixed with the particles of the Osteon Xeno. Okay, so it has very good handling characteristics. And then when it is moist, it tends to still hold together very nicely. So we have certain volume stability when we place this material into our defect. So let me show you a similar case as today's case, so we can have a brief look at what we can expect. This is also immediate implant placement with transmucosal GBR using the Duk technique preoperatively. We can see that there is already an implant placed in the region of 3.3, and there are two teeth that are left with quite high alveolar bone in this area, which can imagine since she has been edentulous in the upper area for quite a long time. This is what it looks like in the mouth. Okay, so as we can see, the plan was to extract those two teeth, two incisors, and place 3 implants immediately. We can see that in this case, a very narrow diameter type of implant was used. It seems to be one-piece implant, which is frequently used in very, very narrow ridges. So these implants have been placed, and also it looks like in this case, the horizontal ridge defect has been grafted using a collagenated bone material, and it has been covered with a collagen membrane. So this is what Duk technique kind of looks like, but the one that we'll be showing you today in today's surgery will be slightly more advanced in the aspect that we will also incorporate a particulated bone substitute as well as the collagenated bone substitute. So this is what it looks like post-operatively. We can see that it was the area of 3.1 where we were missing the most amount of bone. And we can see that this is being well supported by the collagenated bone substitute post-operatively. This is the post-operative panoramic X-ray. Okay, so very interesting. So now we will move to the actual surgery. And now we can see that the implant in the area of 1.1 has already been placed. So the focus of our surgery today will be in the upper right sextant. We can see that a vertical incision has been made posteriorly And now he's making a mid-crestal incision. Yes, the root rest has been extracted in the area of 1-4. We could imagine that this root rest was a floating tooth because there is already the outlining epithelium that has formed the flap. The soft tissue has already been healed around the root. So I don't think we will be having much problem of primary closure when we're suturing. So now he's opening up this flap. You can see, even though we have some soft tissue regeneration around the area of 1-4, it still appears to be quite thin. We can imagine the area underneath there is full of granulation tissues. So he needs to be very careful when he's raising this flap in order to make sure that there is no perforation of the flap, but also to make sure that he can remove those granulation tissues. One of the things that we're looking for when we're raising this flap is that it is raised as a full thickness flap. So there's no remaining periosteum that is stuck to the bone bed, obviously, which can get in the way of bone regeneration when our bone substitute material is being placed. You can see here that he is using the blade 15C. 15C is the preferred choice of blade type when we're performing cases that are very intricate. Now he's raising the flap, and as we expected, there are some granulation tissues in the area of 1-4 still left around the socket. And he is making sure that he is removing all of those soft tissues that is stuck to the bone bed. And just another general point, these type of procedures is what is being quite commonly being performed in general practices now. Since implant placement is not a technique for the specialist, only for the specialist, but also for general practitioners nowadays. And general practitioners are under a lot of pressure from the patients in order to deliver the results quickly. This is why he's placing immediate implants and performing transmucosal GBR. Okay, so he's looking for a suitable place to start drilling. Now remember, the area of 1-4 is where we had the horizontal bone defect. And the area of 1-6 is where we have the vertical bone deficiencies. But I can see from his drilling procedure that he is going to place the implant in the 1-6 area flush so that the implant fixture shoulder is going to be flush with the bone crest. Okay, so sequential osteotomy is now being performed. When you look at this drilling, you could probably think that the axis of the implant is going to be a little bit buccal. This is frequently the case when you're placing an implant in this 1-4 area, the first maxillary premolar area, because obviously we have the canine, which is the buttress of this arch, and that is where the curvature of the maxillary arch is going to begin. So if you can imagine, when you follow that curvature, normally the first premolar implant ends up being placed in the buccal axis quite frequently. But this is what he will have to overcome. he will have to perform enough horizontal bone augmentation to cover the curvature of the maxilla. Yes. We can still see that he hasn't fully removed that granulation tissue just distal to the canine. I'm sure he will do at one stage. Otherwise, I will have to give him a phone call to say, hey, remove that granulation tissue. Oh, okay. He's going to place the implant. I'm sure he's not blind, so he will remove it at some point. Yep, like I said, we can see that the axis of the implant appears to be a little bit buckled, but sometimes this cannot be avoided in this area. He may have to use an angled type of abutment to overcome this problem, and now he's removing the soft tissues around the implant. Maybe a little bit late on than I would have expected from a clinician of his caliber. But he's doing a very good, tremendous job. Yes, we can see that he is using the hand wrench. Obviously, there is plenty of initial stability in this implant, greater than 50 newtons. Yeah, you can see, as we expected, there is a horizontal defect in this area and buccal dehiscence around the implant fixture. So he's going to continue with the drilling in the 1/6 area. And obviously, because he has already placed the implant on the 1/4, he can just perform osteotomy, so it's parallel to that implant fixture. Normally, when we're performing this type of implant placement, we would also be looking at the teeth on the contralateral side, so we can have some kind of guidance into the placement of these implants, and also the size of the teeth as well. But given that there are no teeth on the opposing arch, we will have to look at the position of the teeth on the mandibular area to make sure that these implants are pointing in the direction of the mandibular molars on the right area. Okay. Yes, so there is the implant in the posterior. It looks like a 5mm diameter implant. And as we expected, he placed the implant flush with the crestal bone. So he will be performing further augmentation of the ridge vertically on top of that, is what I would imagine. Okay, and we can see the implant in the 1/1 area has been quite successful. Now we're placing the healing abutment since we are performing transmucosal GBR. And those of you who are wondering what transmucosal GBR is, before, when we used to place implants in the very olden days with the Brandmark implants, with machined type of surfaces, all the implants used to be submerged. But nowadays, with the development of the implant surface and the SLA type of surface, to be more specific, we have better primary stability of these implants. Also, we have faster bone osseointegration of the implants. So we have greater feasibility to perform GBR while the implant has a transmucosal component that is installed at the time of GBR. And the prime concern of when we're performing transmucosal GBR is that the implant and the bone augmented materials are still exposed to the outside. It means the saliva and the blood can still get in from outside, which means it can become infected. So, as many clinicians and researchers have wondered that whether this transmucosal GBR technique can be performed, and there has been plenty of clinical and preclinical research that has been performed for this transmucosal GBR, and we have found out that it can be a very successful technique given that primary stability of the implant can be achieved. So healing abutments have been placed, and we can see he is trimming the collagen membrane. So he is using a collagen membrane as a barrier, and collagen membrane, as we all know, is the most frequently used type of membranes in today's dental practice. Obviously, before the use of the collagen membranes, non-resorbable type of membranes, specifically EPTFE membranes, had been used. But nowadays, collagen membrane is easier to manipulate, and we have a friendlier outcome for the clinicians, even after the membrane exposure. So collagen membranes tend to be much more preferred, especially in general practice. So I thought, there it is. So he just raised the flap a little bit more, a little bit of tunneling in the buccal area of the canine tooth, so he can place the membrane right into that tunnel, into the pouch. We can see that the collagen membrane has a degree of stability. It looks like it's kind of a stiff kind of collagen membrane, even though it is slightly hydrated from the blood. It seems to be holding that stiff shape. Okay, so he's now placing the osteum xenocollagen, which is a soft collagenated block type of material, and he's placing that into the floor of the defect. This is what's going to provide us with the stability, the Duk technique. So now you can just imagine that he is building a barrage from bricks and cement and all those little ingredients that you need when you're building a wall. Okay? So this is what's going into the floor of the defect. And now, since we have stability from the collagenated soft blocks, he is now piling on top of that particulated material, particulated xenograft, osteum xeno, on top of the collagen blocks. So you can just imagine, this is over-augmentation with a lot of materials, and now he's placing the collagen membrane in between the mucoperiosteal flap and the bone graft materials. One important aspect of this technique is that you want to fill this pouch that you have created within the flap. When you're raising the flap, it's important to notice that you don't extend the elevation of the flap too far beyond apically, because that means all the materials that you place are going to be displaced in the apical direction. So you want to kind of create a pouch which can hold the materials together. Now he's moving on to the sutures. I believe he has already performed a releasing incision near the beginning of the surgery. And that is quite a good idea, to perform the releasing incision at the initial stages just after flap elevation, because as you can see now, there is already, the bleeding has stopped. If you perform releasing incisions just before you start suturing, obviously it becomes a lot more difficult because you have all the bone graft materials and the membrane which gets in the way. And also you have profuse bleeding when you perform releasing incision. Oh, the suture has just been, I think there might have been a tearing of the tissue on the palatal, or he just cut off the suture there because he wasn't so happy with the positioning of the entry of the needle. Okay. So he's performing an interrupted suture, but not quite interrupted suture. This is a figure 8 type of suture, I believe. And what this tends to do is it keeps the flap down. It stops the flap from climbing up the side of the healing abutment by performing this type of technique. So when we're performing sutures around healing abutments, we need a different type of technique to what we would normally perform when we are submerging the implant and the bone graft materials. Usually, when we perform GBR, we are looking to evert the flaps on either side by performing horizontal mattress sutures. However, when we have healing abutments in place, sometimes we don't want the flap to be crawling up the side of the healing abutment, so sometimes it is more effective to perform external mattress sutures instead of internal mattress sutures, which are more conventional type of mattress sutures when we perform GBR. But he is using internal mattress sutures in this area, in between the two implants, obviously because he doesn't want exposure of the material, the membrane. And flap eversion is necessary. Okay, so he is using a laurel loop variation. So we have a loop that is going over the flap and it's pressing down onto the flap to stabilize the flap. This can be very useful in the maxillary area. Obviously, this is a different situation to the lingual flap. In the lingual area, when we perform GBR, we have the lingual flap that can be advanced quite far after releasing. But in the maxilla, this is not possible because of the palate. The palatal gingiva is very firm, so it cannot be released. So it's better to use the laurel loop variation of the mattress suture in this case. Okay. We're almost reaching the end of the surgery now. Okay. It looks like he is using a monofilament suture material in this case. And it looks like nylon 50 or 40. Obviously, when we talk about suture materials, we have monofilament suture materials and we have braided suture materials as one of broad categories. And monofilament suture materials, nylon, which is the prime example, tends to be more hygienic because it's monofilament rather than braided sutures, and it is used in practice much more frequently when we're performing GBR procedures. So this entire surgery has been quite short as well, given that he just placed 2 implants and GBR procedure and all the suturing. The time is only reaching up to 25 minutes now. So implant placement, GBR and suture, well, obviously there's incision making as well. So all of that within the time of 30 minutes, which is not bad. And this was possible because he was using this Duk technique, I think, in a way of achieving stability of the materials. Otherwise, if we were to use membrane stabilization devices like fixation pins and perhaps even stabilizing sutures, the entire time of the surgery would have been extended much further. These type of techniques are very useful because it's less time consuming, as I just mentioned, and also it can be less invasive because the flap elevation can be kept minimal. Because remember, if you are fixating a collagen membrane or any type of membranes, you'll have to elevate the flap a lot further from the area that you're expecting to augment, because you need space where you can fixate those pins. But in this kind of pouch kind of technique, where the flap is holding the material in place, then we sometimes don't need to, in those techniques, we don't need to extend the elevation of the flap quite as much. And also, we don't have to fixate the membranes. So the time is much shorter. And also, the patients would prefer this type of technique. There will be less swelling after the surgery as well. I wish I could show you a paper describing these advantages that I just mentioned. But I think that will just have to be for another time in another presentation. So, yes, I think, yeah. Oh, I think he's just changing the healing abutment. Maybe it was too short. Because there is a vertical bone defect in that area. He needs a long healing abutment because the soft tissue thickness would be very thick, over 5 millimeters, I would imagine. So there we go. That was the end of the surgery. We will now move on to Q&A, which will be in 10 minutes. Okay, so welcome back. So let's have a look at this case now after it's finished. Compared to the preoperative situation on the left, we have the postoperative situation where we have the implants on 1-1, 1-4, and 1-6 that have been placed. And we can see that primary flap closure has been achieved around these implants. And let's have a look at the CBCT postoperatively. We can see here around the implant of 1-4, we have a very large amount of horizontal augmentation. And look at this, almost in right angles, emerging from the buccal bone plate. We can see that there is this square barrage of materials that is holding the materials in the crestal area from going down into the apical direction. And this is possible because we have stability from the collagenated bone graft material. And also, if you remember, we did not elevate the flap very much apically from that area. So that is holding the materials in place without even any type of membrane fixation or stabilizing devices. And this is under 1-6 area, the implant has been placed into the native bone without any further vertical bone augmentation. Yeah, and we can see from the 3D reconstructed image that the implants, all three implants, had been placed in the ideal location. So let's move on to the question and answers. So these are the questions that have been asked most frequently by everyone. The first one was, how do you perform the Duk technique? Well, I've been explaining all along how you perform the Duk technique. And let me just recap. Duk, in Korean, it means a barrage, a wall for a reservoir. So this is a wall that is creating stability for the grafting materials. So what you do is you elevate the flap, and you only elevate it to the point where you want to perform bone augmentation. And in that area, you you make the floor of the graft materials using the collagenated bone substitute. And in this case, the osteone xenocollagen was used. And then on top of the collagenated bone block, you place particular bone substitutes on top of that to further increase the osteoconductivity in the crestal area. And on top of that, you place the barrier membrane, a collagen membrane in this case, and then the flap is advanced on top of that to perform the transmucosal GBR. Okay, so I hope that explanation was sufficient for everyone. The second question is, in what way is it differentiated from existing technique? Well, the conventional type of GBR, the membrane has always been fixated traditionally. So you use a bone tacks, titanium pins to fixate the membrane, and that is what is stopping the materials from disintegrating, spreading all into the dead spaces around the augmented area. So now the technique is moving in a way that it becomes faster and is effective and is better accepted by the patients in terms of pain, postoperative pain, and also the surgery time. Okay, so when we have minor bone deficiencies and minor implant dehiscences, you don't want to be performing all these very extensive bone augmentation procedures using autogenous bone and a lot of fixation techniques, which can be very time consuming and invasive for the patient. So this is a very fast, effective technique to provide the patients with good results, especially in the general dental practice. So that is all for you today. Thank you very much for watching. I will see you in another time.